by the ISTH World Thrombosis Day campaign and the Division of Blood Disorders and Public Health Genomics at the Centers for Disease Control and Prevention, the CDC. We're delighted to have you here with us for today's webinar, which is going to focus on breaking the silence, addressing mental health in thrombosis patients. Today's webinar is in support of the 10th anniversary of the World Thrombosis Day campaign, which takes place this Friday, October 13th. My name is Alok Khurana, and I'm delighted to be today's moderator. I'm currently a professor of medicine at the Cleveland Clinic Lerner College of Medicine in the US. My clinical and research focus includes cancer-associated thrombosis. For today's webinar, we will be shining a spotlight on mental health considerations for patients and survivors of those affected by thrombosis. Mental health in the thrombosis field is not new to patients, and over the years, we've learned a lot from our patients about how it affects them once they've had the original diagnosis and treatment dealt with. But it has become an emerging area of focus for researchers. Today is timely also because it's also World Mental Health Day, an international movement for mental health education and advocacy against the social stigma of mental health issues. So for this webinar, we brought together leading thrombosis experts from around the world, as you can see on this slide, to bring the latest information and research to you. Let me start off by introducing our panel of expert presenters today. First, Dr. Lana Castellucci joins us from Ottawa, Canada, where she's an associate professor in the Faculty of Medicine at the University of Ottawa and a scientist at the Ottawa Hospital Research Institute. She's also chair of the World Thrombosis Day Steering Committee. Next, we are joined by Dr. Eric De Paula from Campinas, Brazil. He works alongside Dr. Castellucci in his role as vice chair of the World Thrombosis Day Steering Committee. Dr. De Paula is also vice dean and associate professor of hematology at the University of Campinas School of Medicine. We are happy to welcome Dr. Kirsten DeWitt from Queen's University in Canada. Dr. DeWitt is associate professor in the Department of Emergency Medicine at Queen's University in Ontario, Canada. And today she will be sharing more about her research on mental health in thrombosis patients. And finally, today's final presenter will be Carol West from Canada, who joins us as a patient representative on this panel. Carol is a survivor of multiple blood clots, and she will be sharing her story and how she navigated mental health considerations during her journey. Thank you to all of our presenters. And now we're just about ready to get started. But I would like to quickly review a few technical matters and let you know how you can participate in today's session. Firstly, we encourage you to submit questions using the Q&A option available in the webinar. Feel free to post your questions at any time during the presentation. We'll be monitoring questions throughout the hour and saving them, and we'll address as many as we can during the last section of this webinar during the Q&A session. Note that today's webinar will be recorded. We'll be sharing a copy of the recording via email within 1 day of the webinar, and we welcome you to share it with your colleagues. Before we get started, we'd like to learn more about who we have on today's webinar. So here's a poll question about which region of the world are you from? Please feel free to answer using the prompt on your screen. You have a couple seconds for the answers to roll in. Thank you very much. So this shows that we have a very diverse audience here today from really all around the world. Thank you all for being here. It's great to see representation across so many different continents. All right, let's get started. I'm pleased to present and introduce our first speaker, Dr. Lana Castellucci, who will provide an overview on thrombosis and importance of mental health treatment. Over to you, Dr. Castellucci.
Thank you very much, Dr. Khurana. It's an honor to be here today representing the World Thrombosis Day Steering Committee and the ISTH. Next slide, please. These are my disclosures, none of which are relevant for today's presentation. Next slide. Thank you. So as many of you know, this is a very exciting year for the World Thrombosis Day campaign. 2023 is our 10th anniversary. And our campaign theme is Move Against Thrombosis. As you can imagine, this has many connotations. It not only talks about movements and physical activity to reduce thrombosis, but we're also talking about movements to increase awareness and education to other aspects of VTE care, including the psychological impacts of VTE. Next slide, please. I'm going to bring us back 10 years to the founding steering committee group, which was a very accomplished group of researchers and clinicians. And this group wanted to understand what the burden of thrombosis was on a global disease perspective. And in order to do that, they conducted a systematic review and meta-analysis. Next slide, please. And what we learned from this review were some very important facts. 1 in 4 people globally are dying from thrombosis-related causes. And specifically, when we look at venous thromboembolism, which comprises deep vein thrombosis or blood clots in the legs, and pulmonary embolism or blood clots in the lungs, that VTE is amongst the top 3 cardiovascular causes of death. Next slide, please. We also learned from this review some basic epidemiology about VTE. Globally, the annual incidence rate of VTE is 1 to 2 persons per 1,000 persons will be affected on an annual basis. And there are some factors that increase those rates, importantly, increasing age. When we look at individuals who are age 70 and older, we see that their rate increases on an annual basis to 2 to 7 persons per 1,000 persons. And there are other risk factors that we're aware of, things like hospitalization, comorbidities, and other sex and gender related risks. Next slide, please. Further back to this original steering committee, they wanted to gain a better understanding of what the world knows about venous thromboembolism. And in order to do that, they conducted a survey in 9 different countries, and they had 800 people respond. Next slide. And what we learned from this survey is that we need to do a better job. We need to have campaigns that increase awareness about venous thromboembolism. And we need to do that because they're largely preventable thrombosis disorders. And when we bring this down to what we talk about on a day-to-day clinical basis, we really want to talk about what are the risks of untreated DVT and pulmonary embolism. And I'm going to use some Canadian numbers, which can be translated to your own country. And we know that in Canada, between 40 and 50,000 people are diagnosed with DVT every year. And these are largely diagnosed in emergency departments and with family physicians. And unfortunately, there may be a delay to diagnosis of DVT and pulmonary embolism. And undiagnosed and untreated DVT carries a risk of about 50% of people developing pulmonary embolism. And again, when there's a delay in diagnosis of pulmonary embolism, that can be associated with a 30% mortality rate. And sometimes it's related to delayed presentation or investigations for those symptoms that mimic other disease processes. And so other things are evaluated first, and unfortunately, DVT and PE may not be top of mind, and so there may be a delay. Other things that can lead to delayed treatment or initiation of treatment can be affordability of medications and access to medications. Next slide, please. And so this carries significance from VTE perspective. And I've broken this down into 2 different phases, what I'm calling the acute phase, where individuals are diagnosed with their VTE. And as I mentioned, there may be a delay in that diagnosis. And associated with the diagnosis is now a new area for most people where they're initiated on anticoagulants. And anticoagulants carry their own risks with them. So this can be overwhelming for some individuals. And then there's the next phase of care, which I'm calling the chronic phase or secondary prevention phase. And many patients will describe persistent symptoms. And when we talk about pulmonary embolism, those symptoms are often breathlessness and inability to do their usual activities, which can decrease their quality of life. Next slide, please. So all of this implies that there are psychological impacts of venous thromboembolism. And there are many studies that have looked at validated tools and scores to assess different areas in a person's life. When we talk about quality of life, people are reporting a reduction. And similarly, there's a reduction in their functional status or abilities. And in accordance with that, what we're seeing is that there's an increase in diagnosis of depression-related disorders, including anxiety and PTSD. And some people are also affected from a more economical perspective, where there's increase in unemployment rates and healthcare costs. Next slide, please. This is a snapshot from our World Thrombosis Day website, and I invite you to come and see worldthrombosisday.org. We have many great resources available here. And what I'm highlighting here in this snapshot is something called My Clot Story, where we go and ask individuals who are VTE survivors, patients, or caregivers to provide their story. And we're hearing and seeing words and emotions such as suffering and fear, worry, and scary that are coming up repeatedly. Next slide, please. All of that, again, highlights to the psychological impacts of venous thromboembolism. It's important for us as healthcare providers to listen to our patients and recognize when they're describing this, and to acknowledge that they're not alone in these feelings and that there are supports and treatment available. But in addition to listening, we may need to ask our patients and be comfortable asking, because they may not be comfortable sharing it, or they may not even recognize it in themselves. Next slide, please. I'm going to finish with this slide, which is a tool available on our website, and it's meant as a tool for individuals to understand high-risk settings of VTE and have an open dialogue with healthcare providers about those risks and ways to reduce that risk. And now I'm going to hand over the presentation to my colleague, Dr. Kirsten DeWitt.
Thank you, Elena. So I'm going to talk today about anxiety and post-traumatic stress disorder after pulmonary embolism diagnosis. So I'll start by telling you a little bit about the setting where I came to do this research. I'd been working as both an emergency physician and a thrombosis physician in McMaster University in Hamilton in Canada for about 6 to 7 years before I embarked on a research study specifically looking at mental health in pulmonary embolism. So until that time, I had an understanding that my patients sometimes seem to have some mental distress. And the most common way that that manifested would be around the discussions about perhaps stopping anticoagulation or changing the dose of anticoagulation. And I noticed that just very occasionally, there would be a glimpse of fear or anxiety or distress in that person's face when we discussed that. But other than that, I was really quite ignorant about the extent of the traumatic distress that people have experienced. And I had been doing some reading on other people's research, and there had been some great research coming out of the UK looking at anxiety and post-traumatic stress in patients who'd been diagnosed with venous thromboembolism. And Rachel Hunter had published a paper describing anxiety and persistent traumatic symptoms in people who'd had pulmonary embolism. And about that time, I had an undergrad student who approached me, Anna Tran. She had a previous interest in psychology and had asked, could she look at starting a research project with me? Next slide, please. So together, we planned and conducted this research study. So the study was based in our Hamilton Thrombosis Clinic. The clinic runs between 9 and 5, Monday to Friday, and there are about 6 physicians, including myself, who had staffed that clinic at the time. And the study really had Anna, our undergraduate student, camp out in the waiting room, and she approached patients after they'd booked in, when they were waiting to see the physician, to ask if they'd experienced pulmonary embolism. And those patients who had experienced pulmonary embolism were eligible to participate. She gave them an iPad, and the iPad had a list of questions in a survey, including a validated method for measuring post-traumatic stress disorder. We had about 72 patients who completed that in the waiting room. And at the end of the survey, they were invited to a confidential interview with Anna. And about half of those people took up that offer. So the interview was conducted in one of the consultation rooms with the patient who was waiting to see the physician. And of course, they could bring a family member or friend with them if they wanted to do that. So in brief, what we found with the study was that 2 out of the 72 people who completed the survey could tentatively be diagnosed with post-traumatic stress disorder, which equates to 3%, which seems to be a little higher than you would expect in the general population. And then when we analyzed all of these in-depth interviews, we found that roughly half of these people who had experienced pulmonary embolism had ongoing psychological distress. And that distress manifested in many ways. And these people, some of them had been diagnosed with pulmonary embolism a month or 2 before, but the vast majority had had pulmonary embolism at some time in their past, and it could have been, decades ago. Next slide, please.
I had very, very tight chest pains. I was very dizzy and nauseous. The pain was radiating up my neck and down my arms. I could feel it across my back, and I couldn't take a deep breath.
When we analyzed these interviews, we looked at what are the common themes that people who are experiencing this ongoing psychological distress. And the first theme is illustrated by this quote. And I should say that the quotes have been recorded by co-workers. So none of these are the people who were interviewed. So the first theme was people who were experiencing ongoing psychological distress tended to recall the time that they presented or experienced pulmonary embolism as being physically traumatic. And pain was a very common symptom. So this person, for example, commonly thought back to that time when they had these terrible symptoms of chest pain, dizziness, and they were nauseated. And it was physically distressing for them to recount those symptoms. Next slide.
The doctor told me after, when I was leaving the hospital, a lot of people don't get through this. I was one of the lucky ones.
So the second theme that we found was distress in recalling how the diagnosis of pulmonary embolism was broken to them. And most people are diagnosed in the emergency department, although clearly some people might be inpatients in hospital. So this was an example of what one of these participants told us. He could recall the doctor telling them that they were lucky not to have died. And that thought had played on his mind over and over again. And this is troublesome and puzzling to me as an emergency physician, because I can't imagine telling a patient that they're lucky to have survived, but perhaps in the heat of the moment, we do suggest something like that. And in the heat of the moment, it's quite possible that somebody just receiving the diagnosis of pulmonary embolism would hear that. And this, unfortunately, had caused repeated distress to the patient. The next quote is actually an example from another study.
Like he said, you have a saddle. And I thought, what is that? But they were all in a hurry, and they were bringing machines and do this and hook me up and all that. And I didn't have a chance to say, please explain exactly what that means. I don't understand. All I know is I have blood clots in my lungs. So there really wasn't an opportunity to sit down and have a conversation with somebody. They all had a job to do, and they were all busy.
So this comes from a study that was conducted about the same time in the States by Dr. Hernandez Nino. And she very cleverly explored really the communication between healthcare practitioners and people who were just being diagnosed with pulmonary embolism. And I think this beautifully exemplifies a few problems. The first being that these healthcare practitioners were using technology and they were using jargon that no patient would ever understand. So for example, using the word saddle makes no sense. I understand it makes no sense to a patient, and it hardly even makes sense to somebody who works as a physician in the emergency department. And by using that jargon, they were preventing that person from participating in their own decision-making around the treatment for their pulmonary embolism. And one of the things we see a lot is the feeling that there's a lack of control over the situation or a lack of control over somebody's health after the diagnosis of pulmonary embolism. And one way we can give somebody the lack of control is by giving them the opportunity to be involved in decision making. And unfortunately, in this circumstance, there was so much going on around the patient, they didn't feel that they could ask for additional information. Next slide.
I went to another country and I flew there, so it was a very long flight and I was on blood thinners. But still, when I got there, I was extremely stressed that I was having another blood clot.
Another example of the third theme that we found, which was that people who had ongoing psychological distress had repeated fear that they were experiencing recurrent blood clots. And this person, when they told us this, they actually said, you know what, I sort of realized I probably wasn't, but I just couldn't get rid of that worry and fear and anxiety that this was another blood clot. Next slide.
When the doctor said it was a blood clot and it could go any minute, I could have a stroke, I could have a heart attack, that was a whole other ball game. That has got to be one of the most traumatic things in my life.
And then a fourth really important theme that we discovered was that actually many people who've experienced blood clots, and perhaps have had even more than one pulmonary embolism, don't understand the exact physiology. And that's really on us as healthcare practitioners, because almost nobody who has pulmonary embolism would go on to have a stroke or a heart attack. They're two different disease processes, but we're not telling our patients that they don't need to worry about heart attacks and strokes. And that's a really big information gap. Next slide. So my take home from this research is that as a healthcare practitioner, we need to do better. I need to do better. My colleagues need to do better. And I think the first place we can start is by giving upfront, reliable, and accurate information. And that information should be the same and repeated at intervals. So the emergency physician gives the same information as the follow-up thrombosis or internist in clinic, as ongoing, for example, family medicine practitioners. So we need to improve upon that. Next slide. So to summarize our findings, we found that the experience of pulmonary embolism diagnosis is often frightening. And people who experience pulmonary embolism often suffer from being given inaccurate information or a lack of accurate information. People experiencing pulmonary embolism often feel isolated to the extent that sometimes they feel like there's something wrong with them or that they're abnormal. And all of this just creates the perfect circumstances to develop anxiety and depression. And overall, healthcare professionals can do better at preventing this. Thank you.
Good morning, good afternoon, and good evening, and thanks so much for the invitation to be part of this important focus on mental health. And I'm speaking as a patient. So my first slide has a picture of my leg. More specifically, my knee, because this is where my VTE experience started. It started right here. Next slide. So a fall on a rainy day, a shattered kneecap, surgery to wire things together. So far, so good. I didn't really have any consciousness of blood clots at this point at all. However, immobility during recovery and no anticoagulation resulted in a loss of muscle mass and mobility and development of bilateral DVTs, which wasn't so good. Then came the PE, or pulmonary embolism, which was diagnosed sometime later in an emergency room, as many are, and that was really not good. So over a period of weeks, my life changed, and indeed, it changed forever. And maybe more importantly, this could happen to anyone. I always say my experience is fairly mundane in terms of the fact that this could happen to you. It could happen to anyone. Next slide. I'd like to just talk a little bit about the mystery of blood clots, because I think that anytime there's mystery, fear is inevitable in terms of things we don't know about. And certainly the observation that Dr. DeWitt made about repeated messaging and clarity of messaging is so important. So first of all, is the blood clot provoked or not? I learned in my case it was provoked. It was very clear why I had a blood clot, and it was not a complicated, complex genetic condition or other sort of medical condition that led to this. It was quite straightforward as blood clots go. Many patients don't have this experience. In fact, their experience is more complicated. It's more detailed from a complexity point of view from a medical perspective. But I think what we have in common as patients is that we're healthy one day and maybe not healthy the next, and that is a problem. So again, symptoms are not always obvious with blood clots, and nor are the remedies always obvious, and they often require considerable knowledge, considerable discussion with healthcare providers, and all around this mystery surrounding blood clots is fear. Fear is an inevitable companion, I believe, and it certainly was for me and my experience. So I've been thinking about my particular experience as a patient, and let me just say a couple of things before jumping into this slide. One is, I'm a woman of a certain age. So I made decisions in my life about things like career, children. I didn't have pressures of social media when I encountered the world of blood clots. So I count myself lucky in that sense. Also, count yourself lucky if your job does not rely on physical activity. Some people have to face that need for mobility as they are recovering and healing. And although I did travel a considerable amount in my job, it wasn't a requirement that I be on the road all the time. And certainly that part of my life was very much affected by the fact that I had blood clots. Secondly, count yourself lucky if your employer is understanding through recovery, because that may not be the case for everyone. I certainly had an employer who was partly understanding, but the employer obviously is looking to make sure they deliver the services or the experiences or whatever that you provide in your job. So the employer has priorities beyond you. So you're lucky if your employer is understanding throughout your recovery. It's also important that you're financially okay for living expenses and treatment. And as you know now, I was fortunate enough to have this blood clot experience in Canada, which has a very comprehensive healthcare system in terms of cost, in terms of the ability to get treatment and accessibility to treatment. So this was not an issue for me, and I'm grateful that it wasn't. Also very important that you have a physician who understands clots and discusses treatment options with you. Now, that may be your family physician. It may be a thrombosis specialist, but again, it's important for you to be able to ask questions. It's important for you to feel that you can be frank about your concerns, about your apprehensions about your lack of knowledge with thrombosis. So again, these are some of the conditions for wellness. And if you have those, count yourself lucky. Now, this photograph is not to illustrate that I taught my dog during my recovery to bring me a glass of wine in the Sunday New York Times. That didn't happen. However, again, for me, it was important that I didn't live alone. So small things with physical help, movement, meals, other kinds of things. It was important that I didn't live alone. However, I know that that's a bit controversial because in some people's living arrangements, if they don't live alone, it's not a helpful, constructive environment. So again, I qualify the you don't live alone. And I go to the next point that is really, really important. And that is that you can ask for help, even for small things. And you can enjoy small things, even if you've had to ask for help for them. I have one example, which is that, again, I had to ask a niece to drive me to a medical appointment. And for me as an independent person, I thought, I'm not so sure that this is comfortable for me in terms of being able to get that kind of help and support. Now, even if you have all these things that in my experience, I counted myself lucky to have, you may still face mental health challenges. And that is another consideration as you recover, as you consider what your life is going to look like moving into the future. So the next slide is about supporting mental health in VTE patients. And, those of us who have had a thrombosis experience, we manage risk every day. And that risk is primarily, do we want to clot? Do we want to risk a bleed? Like, what are our choices of medications? How do we then live our life going forward? Because our quality of life may have changed considerably. And the questions we ask then is, where did it go and what can I do about it? I see that there's already a question about that in the Q&A, and happy to have that conversation after this. But, again, it may be as simple as your experience with hiking. It may be as simple as your experience with skiing and the concern about falling and hitting your head. I've done a lot of volunteer work. I can't stand for long periods of time anymore. I can't sit for long periods of time anymore. So it's not going to be me at the table at the fundraiser standing for 2 hours at a time as I used to. So again, support is helpful. And I would say in this that I don't believe COVID helped for people who are more recently diagnosed. I think the social isolation and restrictions on your life combined with a VTE diagnosis and management is complicated and maybe was not the best. How research helps. I am associated with the CanVector network in Canada, and I cannot say enough good things about CanVector from a research point of view, maybe more importantly from a leadership point of view, a vision point of view. CanVector has created meaningful spaces for their patient partners and meaningful opportunities for input. And I just want to talk about very briefly about the 2 projects that have specified the reflection of patient priorities in research and outcomes that are important to patients. And one was the Clot Top 10 James Lind Alliance Priority Setting Partnership. We hope researchers will look at those priorities because one of them is about psychological impacts. What are the psychological impacts of a diagnosis of DVT or PE, and how can they be measured? And how can people be supported to reduce anxiety and improve quality of life? I think the patient voice was heard in terms of our concerns about this, and we're delighted to see that it's part of Clot Top 10. And with our VTE cause study, which is an international study across borders, can we move 2 slides on, please? The next one, there we go. You'll see in that center piece that it is about patient-reported outcomes lacking in this VTE cause study. We're very interested in this. And it's not only the physical attributes, but it is also anxiety, fatigue, and quality of life, which I've just spoken about. So to wrap up, I'd just say we're all part of the solution to tackle mental health challenges. And I would challenge everyone to just ask how you can help break the silence. It's incredibly important. It's important to patients. It's important to all of us who are participating in this webinar today. So thank you very much. And it's my pleasure now to turn this over to Dr. Eric DePaula.
Thank you, Carol, and thank you all for inviting me for such interesting discussion. The task that was attributed to me is to discuss with you how we healthcare professionals should organize ourselves in order to include mental care as part of the care that we provide for our patients. I must anticipate that this task could not be fulfilled using the usual strategies that we rely on in the medical field, which is to look into the scientific literature and find models supported by robust data on what the best practice would be. Nevertheless, this does not preclude us from putting together ideas of what should and should not be done. So my intention in the next 10 minutes is to provoke some of these thoughts so that we can have a productive discussion in the end. This slide shows an overview of the presentation, which will discuss evidences, goals, challenges, and models. So if you can move to the next slide, please. As I mentioned, there is very limited evidence on strategies to implement mental health care for VTE patients. What we do have are anecdotal reports on strategies focused on patients with other cardiovascular diseases, which can be insightful for this discussion, as well as good quality evidence that integrated healthcare models are beneficial in chronic conditions. The next slide illustrates this clinical trial that demonstrated that a medically supervised nurse working with primary care physicians in a model of collaborative care with emphasis on education led to several beneficial results for patients with chronic conditions such as diabetes and others, including several mental health outcomes. But as we show in the next slide, this discussion will narrow to the context of VTE. Next slide. So if we look at the evidence of mental health impacts of VTE, and building on a model that was proposed for patients with peripheral arterial disease, I believe that the main goals of any strategy focused on VTE patients can be summarized in this diagram that mentions 4 topics: addressing comorbid mental health conditions, promoting health behavior change, addressing the mental health impact of classical VTE complications, and last but not least, providing support for the specific psychosocial issues related to VTE, which have been explored in this webinar so far. Next, as for the challenges, we could highlight the long-entrenched convention of separating the delivery of care for mental health from the care provided by specialists, the fact that interdisciplinary care, though increasingly recognized as essential for the management of chronic conditions, is still not widely available nor stimulated by the organization and reimbursement of our healthcare services, and the limited awareness of the potential role of the physician in helping VTE patients coping with their mental health issues related to their illnesses. So there's some expectation that this should be done by other healthcare professionals. Next slide. In regard to what should be the pillars of any such strategy, I believe that we could all agree that they fall within the domain of what has been called patient-centered care, in that it needs to be technically effective, sensitive to patient needs and expectations, capable to stimulate and support constructive patient participation, and of course acknowledge the impact and the value of the words of healthcare professionals, as has been previously mentioned. As I mentioned before, integrated healthcare solutions are effective in delivering these results. However, these solutions exist in a wide spectrum of organizational complexity, and I would argue that for VTE patients, a sufficient level of integration would be that of different healthcare professionals sharing treatment plans and common goals based on regular communication. So what would be these common goals? In the next slide, please. Allow me to finish this discussion revisiting these goals and detailing them, the ones that we presented earlier. So let's start with the comorbid mental health conditions. The main topics in this area would include the acknowledgement that these patients have an increased prevalence of depression and anxiety, and the need to provide adequate treatment for these patients for these conditions, despite the fact that they are on anticoagulation. And of course, the timely referral, not too early, not too late, for mental health professionals such as psychiatrists when that is needed, which should not be always, of course. Next slide. In regard to the health behavior changes, we need to look in, of course, we need to promote weight loss, smoke quitting health habits. But in order to do so, we have to acknowledge that the perception of illness, the way that they represent their diseases vary a lot among patients, and that any strategy to promote health, these changes, the behavior changes need to take this into consideration, so that simply enumerating the risks based on a strictly medical perspective is not effective. And here, there is a huge role for good quality educational resources and for integrated care strategies. In regard to the impact of classical VTE complications, post-thrombotic syndrome, particularly the severe forms, and cardiovascular sequelae can strikingly modify the lives of these patients and demand for more complex and integrated healthcare models, maybe ones different than the ones that we are mentioning, that are capable to provide specific support for chronic pain, heart failure, and neurological disabilities. And finally, in regard to the specific psychosocial issues related to VTE, they have been discussed and they can be generally grouped into those related to the fear of new clots or fear of bleeding, and also on the reliance on the capability of the healthcare services to provide safe and effective care. So healthcare professionals dealing with VTE patients should be aware of these issues, and some nice work has been demonstrated, and also to the fact that they vary a lot among patients, so as to prevent, to address, and importantly, to avoid worsening them. This diagram, which is part of a commentary from our co-presenter Kirsten DeWitt, nicely summarizes these issues and provides a framework for the prevention and treatment of mental health issues for VTE patients. So, in conclusion, I hope I could convey the messages that we still have a lot to work to do to integrate mental health in the care of VTE patients, that these strategies should fall within the concepts of patient-centered care, that listening to our patients' perceptions, which can vary a lot, is key to this process, that collaborative work and good quality educational resources are very important for this process. And in the last slide, I must just emphasize that discussions such as this one that we are having here are critical steps so that these ideas can spread and mental health care is more and more considered as part of the care for patients with VTE. So thank you very much. And now I turn it over to our Dr. Khorana.
Great, thank you so much. And thank you really to all the speakers for very insightful presentations. This is a really challenging topic. And it's a topic that has been brought up repeatedly by patients, and I'm glad to see that there's so much work being done, as we've heard from all of our speakers, about various ways to support mental health in patients who are either being treated, were just diagnosed, are being treated, or are recovering from a blood clot. I work at the Cleveland Clinic, where I primarily focus on cancer patients, and cancer patients, in addition to carrying the diagnosis of cancer and now the diagnosis of VTE, have additional mental health considerations. And so it's been striking to me how much patients prioritize mental health recovery and mental health aspects of the treatment and recovery from thrombosis. And I'm glad to see sort of all of you coming together to bring all of these efforts to improve both the research aspect of it, but also the clinical aspect and the clinical implementation of this type of support that patients have been asking for. I think we have time for questions to go through. So we'd like to open the floor. We know this is a very popular topic, and so we'll try to get to as many questions as we can. Again, as a reminder, please ask questions in the Q&A box within the webinar platform. We've been triaging those questions, and I'll try and get through those as quickly as I can. Let me start off with the questions that came in. So in terms of the World Thrombosis Day's theme of Move Against Thrombosis, the question is, how can patients know how much daily movement at a minimum is needed to be beneficial after a diagnosis of DVT and PE? And what can patients do when other co-occurring medical disorders complicate getting movement in daily? And I think, Carol, you spoke a little bit about this, which is that it's not quite as simple. It's easy to say, well, do this, do this, do this. But not everybody has access to, doing whatever this is, and not everybody has the ability to do it, and not everybody is able to do it for a variety of different reasons. Carol, did you want to speak to this? And then I'll turn to Dr. Castellucci after that to get her insights on this.
Sure, question. Thank you. Happy to do that. This is such a difficult question because there is fear. And because you are not feeling well, you are not feeling strong, you are feeling inhibited to resume daily activities as you might have done them previously. For example, the issue of shortness of breath is considerable. And again, it is frightening in terms of knowing what is happening to your body and what is okay. I had some success working with a personal trainer, not a physiotherapist, a personal trainer who specialized in rehabilitation, injury recovery kinds of training, and that helped to feel that there was expert visibility how I was moving, how I was breathing, what I was thinking. So that kind of feedback was good. But this is difficult, and this is very common through patients. So don't feel certainly that you're alone in terms of understanding how to get back moving, but start small too. Nothing is wrong with starting small and going for short walks, and then maybe increasing your pace, and speaking to your physician if you continue to have symptoms that are really troubling to you, like the shortness of breath or any kind of pain as you do that. So good luck. And you're very much heading in the right direction in terms of looking to incorporate as much daily movement as you can.
Great, thank you. Dr. Castellucci, did you want to comment on?
Thank you. To build on Carol's comments, which are spot on, that's exactly what I tell my patients. I tell them that they need to be patient and that they will gradually get back towards their usual activity levels, but it may take time, and that there is certainly going to be some limitations, and that they need to start small and gradually build themselves up. Even some of our healthiest patients are marathon runners, triathletes, and they come down with a VTE for whatever reason, and they are very much looking forward to getting back to their usual activity level, acknowledging that they can't do what they used to do immediately. And so we talk about building back towards what they used to do and recognizing when their body is telling them to slow down and even stop, because you don't want to push through that, and you do want to take those breaks as needed. So I think that's just the message that we need to ensure that people are hearing, that it's going to take time to get there.
Great, thank you. So moving on to the next question, this is about the inconsistencies with patient education and diagnosis. I think Dr. Dewitt, you spoke to this already in some of the patient audio samples that you played. And clearly it seems to be an issue that affects patients in many different institutions in many different parts of the world, which is that physicians and generally the healthcare team that's taking care of acute VT is so focused on sort of the urgent nature of the diagnosis that the ball can sometimes be dropped in terms of explaining to patients what's going on and then following up with them over time. So this question is about how do you address the inconsistencies? Do you have standard handouts or education to emergency room providers to ensure that the message is delivered as appropriately as possible? Did you want to take a stab at this, Dr. Dewitt?
Certainly, and I've definitely changed my practice since doing that research. So yes, we always give out some standardized patient leaflets in the emergency department, which I've been able to link in, as soon as the diagnosis goes into the computer, that's going to print out for the physician to give to the patient. Every country has a different body, which is responsible for creating some standardized information. Here we have Thrombosis Canada, and those are the information sheets that I use, but there are certainly information leaflets available from many different organizations. So I think, first of all, is giving them something that they can refer back to when they leave. And it's also very helpful if they have a website that they know is reliable. Because if you just go onto Google, it's quite horrific, the information that you get from Google about really very focused on death. And a lot of people who sound like they know what they're talking about say a lot of things that I completely disagree with. So knowing where is a reliable online place to go, or several reliable online places to go, goes a long way. And then having that repeated standardized information, which is very hard when you're dealing with hundreds of different physicians. I am pleased to say that the ISTH is now running an international group project to create standardized communication for people who've just been diagnosed with pulmonary embolism. We're sort of at the outset of that project, but the hope is that we can actually publish some standards for what sort of topics should be covered at what time in the patient journey.
Great, thank you. And since you have the opportunity here to talk to providers from different institutions, very quickly, Dr. DiPaola and Dr. Castellucci, do you also have standardized handouts, or do you have a standardized way of informing patients about their diagnosis and follow-up? Dr. DiPaola first, and then Dr. Castellucci.
Thank you. Yes, we do have a few handouts, but we actually are working on one that can be delivered at the emergency room, because the ones that we have are mostly at our thrombosis outpatient clinic, which is very late in the patient journey. So I think that the idea of having this earlier is very important.
Thanks, Eric, and thank you, Alok. It's really important. I also work in Canada, and so I frequently refer my patients to thrombosiscanada.ca for our handouts, as well as other resources and webinars that are published on the website. But importantly, World Thrombosis Day has resources available as well, and they are published in other languages, and we are working to continue publishing in many different languages. And we're working with our other partners to try to consolidate our information to reduce that duplicity so that we're sharing information and that people can share these resources amongst their networks so that people have that reliability and resources to go to.
Great, thank you. Carol, you wanted to say something?
Very briefly, I just wanted to say that please make sure that patients take a look at whatever is being developed and documented. We do lots of work on knowledge translation in the form of evidence summaries from a research perspective, but it's also important that patients take a look at this kind of information that's disseminated and provide as much helpful commentary as we can. Thanks.
Yeah, that's very important. And I think, again, it's very important to consider the source of the information that's being provided to patients. I think we do have a somewhat biased sort of group here because we are all people who are deeply interested in thrombosis and in sort of ensuring that, appropriate education is delivered. But that's obviously, probably not true across every institution around the world. As you mentioned, Dr. Castellucci, there are plenty of reliable websites that offer free patient education. I volunteer for Stop the Clot, which partners with the CDC in the United States to deliver patient education. And similar to what you said, there's really good handouts and information that's available online from some of these websites. And I think it's important that patients access that, but not just simply Google it and look at sort of the first few links that pop up. So moving on to next question. This is about returning to activity. We've sort of talked a little bit about this already, but it's about returning to activity after a diagnosis of VTE. So patients leave the emergency room, they're on anticoagulation. What's the communication to like a physical therapist to say it's safe to resume exercise? Is there a standard way to do this? Obviously, it's important that patients sort of, resume activity as much as possible. I'll start with you, Dr. Castellucci. Do you have standardized ways of doing this? Is it more individualized based on what's happening with the patient?
Yes, thank you. It's a great question and very common question that we hear from patients that they work with a physiotherapist. And another common one that I get is I frequently go for massage therapy. Can I get a massage, or is that clot going to move? And so with that, obviously we want to ensure that people understand the importance of taking their anticoagulant to reduce that risk of embolism, especially very early on in their VTE diagnosis. But I tell them, very similar to what I mentioned earlier, to gradually build themselves back up in terms of exercise capacity and work with their physiotherapist. And similarly with massage therapy, to review those very similar sort of recommendations.
Great, thank you. Then the next question is about existing mental illness. So these, obviously depression, anxiety are very common, very prevalent in the general population. On top of that, now you get a new diagnosis of acute VTE. How do you consider existing mental illness and ongoing medications when treating somebody with a new diagnosis of acute VTE, both in the short term and the long term? Dr. DiPaola, did you want to take a stab at this?
Yes. Yeah, this is very important because some of the medications used for the treatment of depression, for example, can also increase the bleeding risk. So this should be considered, not in terms of not treating the patient with anticoagulant, but of course in being more cautious and more watchful about the bleeding risks. But another key message that I think that was something that I could get from both reading about this topic and also discussing a lot with colleagues is that, for example, here in Brazil, depression is mostly treated by family practitioners and psychiatrists. And the idea that for milder cases that are adequately managed by family practitioners, you can do that and you can communicate with these colleagues You don't need to refer all patients to a psychiatrist because most of the treatment can be conducted for both conditions.
Yeah, that's a great point. We don't want to overburden the patient with too many visits and too many providers. So if you can develop standardized algorithms to manage this, or have people with expertise educate providers who are already treating acute VTE to also manage this, it would be very helpful for patients. That's a great point. Thank you. On the same theme, the next question is about how many individuals with psychological distress after VTE have experienced depression and other mental illnesses prior to their VTE. So I guess this is asking about prevalence of VTE, prevalence of psychological distress before and after a diagnosis of VTE. Dr. Dewitt, you're one of the world's experts on this. Can you inform us on?
Great question. And I think definitely theoretically, you might think somebody who has a history of depression or anxiety may have a higher risk of distress after pulmonary embolism. But it's amazing to know that really there has been so little research done on this that we don't even have a good hold of the predictors of developing psychological distress following the diagnosis of pulmonary embolism. So, for example, there has not been a large cohort study that has looked at the baseline demographics of somebody and tried to relate those to the people who develop distress. And that's just to say that we really are far behind in this research. We need to do better. So while I can't say there's evidence to support that, then there's certainly a hypothetical argument to say that perhaps someone with a history of depression and anxiety might be at risk. But I think we have to watch this space and we have to do more research.
Yeah, absolutely. Thank you. Another question is about a population that we didn't specifically address today, which is the adolescents and young adult population. So we're talking here now about teenagers, people in their late teens, early 20s. We often see this surprisingly because these are usually healthy people, but we often see this in the context of sports or in the context of oral contraceptive use. And so the question is about adolescents and young adults who experience impaired mental well-being and anxiety after a first episode of VTE. And the questioner is asking whether the young are more prone to adverse effects related to mental health, and do we need to have a different approach in the younger population? Dr. Castellucci, is there research about this? Do we know more about this?
It's a great question, and I don't treat many adolescents in my practice. I think the youngest that we see in our adult practice is really when they're transitioning from 17 to 18 years old, and they end up in our thrombosis clinic. So I can't really speak to my experience with that early population, but I would say that I think consistent messaging is really important, both for the individual and their families, because their families play a large part in their VTE journey and treatment. And so we need to have reliable resources available for them. That helps to really emphasize that they're often, as you mentioned, related to risks like OCP use or sports injuries and things like that. And so it's not necessarily going to be a long-term part of their health moving forward. And so there's some reassurance there that I think we can provide, but it needs to be done in a more systematic way.
Great, thank you. I think we have time for one more question, and then we have to close up. We only have 2 minutes left. This one, maybe Dr. DiPaolo, you could answer. How important are psychological education programs to patients? And can you provide some information on specific examples of such programs to the audience?
Yes, well, this is a very nice question, and this is kind of a standardized approach of dealing with the heterogeneity of the way patients see represent their illnesses, and they react to their illness and so forth. So doing this in a systematic way, following methods that guide how you should communicate and things like that. There have been examples in other areas, but I am not aware. I could not find any specific experience, at least in the literature, in the context of the VTE. But I'm pretty sure that the overall concept of psychological education is very much applicable to what we all have said.
Great, thank you. So in interest of time, I think we'll stop here. I again want to thank all our presenters and our patient survivor for sharing her story, which I know is challenging, especially in front of a large audience like this. So thank you also to the audience so much for being so engaged with this topic and for all of your questions. As I mentioned at the outset, this is a very important topic for the patient community, and I'm glad it's getting as much attention as it finally deserves. We'll be happy to follow up after this webinar to address additional questions as possible. Thank you all for sharing your expertise. Please be on the lookout for a follow-up email that will contain a recording from today's discussion, and please feel free to share that with your colleagues and whoever else you think is interested in this subject. Again, a reminder that World Thrombosis Day is coming up this Friday, October 13, and we invite you to join us in commemorating this very important day. There are many ways to get involved this year, so check out World Thrombosis Day's social media platforms for all the latest on all of our global activities, and visit www.worldthrombosisday.org to get involved. Thank you again all for participating and for supporting World Thrombosis Day. Have a great day. Thank you.